distinguished lecture series. My name is Shaukat Ali-Khan, and I'm the Chief Digital and Information Officer for West Yorkshire ICB. Thank you for joining us for today's session, which is being recorded, as colleagues who could not attend live can catch up later. This is the second fireside chat in our distinguished lecture series. Our first one, as many of you may have joined, that was on 22nd of September with the inventor of internet and a couple of other distinguished panelists. So looking ahead, we'll be bringing together national leaders to explore how the 10-year health plan translates into real tangible change across West Yorkshire's places and neighbourhoods. We'll be asking what's working, what could be improved, and how can partnerships, co-production, and data empower neighbourhood teams to improve outcomes. I'm really delighted to be joined today by a fantastic panel, Tom Riordan, Richard Stubbs, and then Rachel Power. I will start by requesting my distinguished panelists to have a quick introduction of yourself. Tom, Rachel, can you please start your introduction?
Thanks, Shaukat. Yeah, Tom Riordan. I'm the second permanent secretary at the Department of Health and Social Care. Just had my year anniversary, my birthday. I've been in the civil service again. I started off in the civil service working on international environment policy in the 90s, doing post-Rio climate change biodiversity negotiations, then set up and ran one of the regional development agencies called Yorkshire Forward, then spent 14 years at Leeds City Council working with and in the West Yorkshire health and care system. So great to be here. Thank you.
And I'll go
Thank you very much.
Thanks, Shaukat. So Richard Stubbs, Chief Executive at Health Innovation Yorkshire and Humber. I will talk more about what health innovation, the networks are in due course, but just think about anniversaries. I think I'm in my 10-year anniversary now of being Chief Exec of the innovation function for Yorkshire and Humber in all its various names.
Very nice. And Rachel?
Fantastic. Okay, well, hello, everybody. I'm Rachel. I'm the Chief Executive of the Patient Association, and I'm delighted to be joining Tom and Richard here today to talk about the role of the 10-year plan. So let me start with a little bit about who we are as an organisation. So the Patient Association works directly with patients through our free phone helpline projects, surveys, and lots of webinars like this. And our aim is to give power to the patient voice, but also to give patients power in themselves in navigating the healthcare system, and then taking everything that we hear and speaking to government, the NHS, and stakeholders about what patients are telling us. And I think the thing about the Patient Association is our mission is very, very clear. It's that everyone should be able to access the health and care that they need to live well. But to do that, we have to have patients working in partnership, and we have to start with patients in the design and delivery of services when it comes to the overall service. But when it comes to the individual, that we have really good shared decision making where we really understand what matters to that patient and how we can work together to achieve the best. I'm not going to talk about anniversaries because it just makes me feel old. So I've only been at the Patient Association for 7 years. And I'm enjoying it so much, I'm not counting. So I shall just leave it there. Thank you.
Yeah. Thank you so much. And then we will come back with a lot of questions, and we are all really looking forward to learning a lot from each one of you. So together we will explore national priorities, practical examples of policy in action, and ideas to strengthen collaboration at the neighborhood level. So before we begin, just a few housekeeping points. As I mentioned earlier, this session is being recorded and will be shared across our communication platforms afterwards. Please keep your microphone muted unless you are speaking to make sure that we have a smooth session. Feel free to turn on your camera if you are comfortable. And if you have any questions during the session, please pop them into the Q&A function. We'll come to those during the panel discussion. Today's session is all about turning strategy into action. And we are bringing together national leaders to unpack how the 10-year plan becomes real change in West Yorkshire's communities. We'll explore what's working, what's need to evolve, and how can we use partnerships, co-production, and data to support neighborhood teams. Before we move into our speaker sessions, I'd like to briefly introduce the Distinguished Lecture Series and the wider program it sits within. This series is a collaboration between the West Yorkshire Innovation Hub and the West Yorkshire ICB, Digital Data and Technology Directorate. Over the next 12 months, we will be joined by national and international leaders and subject matter experts. The aim is to share insights, best practices, and practical understanding of how digital, data, technology, and innovation can support the delivery of the 10-year plan and the life science sector plan across our health and care systems in West Yorkshire. And I think this is also an opportunity for bridging each other with our national leaders, within NHS leaders and international leaders with our region. So we are now. I would request Tom to give us your perspective on with regards to national perspective, and followed by our other distinguished panelists.
Yeah, thanks very much, Shaukat, and I'm really pleased to be here. Thanks for everybody who's listening in and on the call for what you're doing in the health and care system. It's really appreciated from where's the Secretary of State down through the department and NHS England and the central organisations trying to enable the delivery and change that we all want to happen for the people of West Yorkshire. So thank you is the first thing I want to say, and thanks for the opportunity to speak today. I'll maybe put the context into the 10-year plan and the policy direction that's been set, and stick to the now I think well understood 3 shifts that are the main structure of the policy thinking that Wes Streeting and his team have brought in to try and take the NHS and care systems forward. And starting off at first with the one that probably is foremost in people's minds in terms of the here and now, which is hospital to community. We know that the demands on the system have been growing. We know that the demographics of the country are leading to more and more people who need support, and we have recognised in the 10-year plan that we need a way of trying to shift that demand from overstretched hospitals at times of the year to a more community-based, neighbourhood-based way of thinking about services, the idea of neighbourhood health. The reaction and the response of the literally tens of thousands of people who engaged on the 10-year plan was that they really liked the concept and the idea that you try and shift services to suit to a more person-centered approach, where you try and reflect the way people live their lives and the way they work or spend their time, and the idea that you could have access to services that were better placed in neighbourhoods and in the community when they don't need to be in hospitals, and indeed in care homes in social care terms. Most people want to spend their time living independently, healthy lives for as long as possible in their own home, not end up in hospital or end up in a care home. And if they do, we've got to make sure they're treated really well, that we get the best possible treatment for them, and then get them back on their feet if we can, and out back home, or make sure if they are in a care institution that is providing the really person-centered care that everybody would want. The Neighbourhood Health Improvement Programme is probably the one thing I'd talk about. Obviously can get into more detail when we answer questions later, but that has been an indicator, if you like, of just the enthusiasm and energy around this idea, because we had 141 places who bid into that. It isn't like bidding for loads of money. It's actually been in a cohort of like-minded places who are going to work together to try and solve some of these problems and make that shift happen in practice. And what those 141 submissions showed was that brilliant things are happening across the country already. I know they are in West Yorkshire from my own experience, but what we haven't managed to do is to scale them up to a point where they really do bite on the demand pressures and the financial pressures that I'd mentioned before. So we've chosen cohort of 43 to work with at first, who we're going to be working with. I'm really pleased that I think there are 3 places in West Yorkshire who've been accepted onto that, which is more than many other parts of the country. So well done in that respect. Not surprised, having worked in the system myself. And for those who aren't in it, don't worry as well, because we are wanting to really share the fruits of that. But that is really about how do you get to the point where you really get the people at the front line and citizens having much more joined up and, as I say, person-centred service provision happening for them directly. And if I move on to digital, the analog to digital shift, I think there's some really exciting stuff in the 10-year plan around how we can move to utilise the almost unique and world-leading data set that we have in the NHS that reflects the diversity of a lot of the global population. Actually, we have a very diverse population cohort in the UK, and that means that if we can get working really well with clinical leaders, really make sure that people have confidence that the anonymized data set and the protections and safeguards in that for people's privacy are absolutely watertight, which they are in the way that we're developing it. Then the ability to utilize that for research and link it to the amazing changes that and strides forward that have been made in genomics around personalized health, around being able to predict particularly very rare diseases from young children. These are the things that could make a massive difference to people moving forward. So doing that is going to be vital in that to really involve patients and citizens and make sure that they have agency and they understand how their data might be used, but also that they can benefit from it. Just one example from my experience when I was in Leeds, we always found it really hard to deal with the delayed discharge headache. So, how do you make sure that people don't have to wait in hospital when they're well to go out back home, because you're trying to get coordination between home care services, social care, the GP, the specialist services that might be needed on an ongoing basis. And what we did was manage to work with all partners and get to a point where in real time caseworkers were able to see what was happening to an individual citizen and an individual patient, and it dramatically changed our ability to get the right meds in line, get the right transport arranged, make sure that people weren't having to send an email and then wait or ring someone and not be able to get through to get connected. And I think that just that simple idea of freeing up the front line to be able to see real-time casework data about people they're trying to support, and in time I think family members as well, obviously all with the agreement of citizens, is going to be, I think, one of the quiet revolutions that could take place that could make a massive difference. But as I say, it really requires patient citizens to be absolutely confident and at the forefront of making sure that they feel that they're happy with what's happening. And then the third one, and I'll finish, is obviously around prevention. You know, going from a position where we treat people too late for diseases and conditions that if we'd managed to get a bit upstream and we'd seen things earlier, then we would be able to prevent that happening. I saw been doing quite a lot of work recently at looking at women's health and men's health, and the sort of the areas where you need the same approaches and other things where you need different approaches. And I was really struck by two things. One is the opportunity that better joined up neighbourhood type provision for women can provide. So many women who are on the gynecology waiting list, you know, don't eventually need actual, you know, elective intervention, but so if we can work with women early, if they can get access to better services earlier in a very joined up way through their GP in the neighbourhood, you know, that's the sort of area that could make a massive difference to so many people. And men's years of healthy life average is 61.5. And as someone who's come in the second half of their 50s, I know you won't believe that. That really struck me as something it's a sort of here and now. And I think, you know, there's so much we can do on that preventative agenda. There's so much that we're doing already with the, you know, things like the toothbrushing that we're doing in schools with the Colgate partnership, the work that public health do so brilliantly well. But how we get that into the centre of what we do and our thinking is really critical, I think, to give people more agency over their own health and make them realise that actually sometimes small changes in lifestyle and in diet and other things can make a huge difference. We aren't asking people to completely turn upside the way they live their lives. And I think that's the thing that could make the biggest difference on inequalities, which is something that I know we all care about a lot in West Yorkshire. So I'll finish there, Shaukat. There's lots of good stuff happening already. Waiting lists are going in the right direction, although there's been a bit of seasonal stuff in the last couple of months. You know, they've never been going down in this way, in this trend over a few months for a long time. GP access is improving, GP satisfaction is improving. You know, that the money is stable, that there are lots of good things. But I just finish by saying we absolutely realise how hard everyone's working on the front line, how difficult it is at times to deal with the demand pressures. You know, the fact that everybody is doing their best. I'd go back to where I started, you know, just thanking people for that. Thank you.
Thank you very much, Tom. I think very, very interesting perspective, and I think there are a lot of questions we will come back once we are there. But I think it's very interesting to hear straight from you, who's on top of what's happening at the center, and then giving the perspective. So now I think I would request Richard to give us, based on what we heard from Tom, how system level innovation can help in doing a lot of these things.
Thanks, Shaukat, and hi again, everyone. As I said at the start, you know, Richard Stubbs, Chief Exec of Health Innovation, Yorkshire and Humber. Just to give colleagues just a little bit on that. So the Health Innovation Network, we are the innovation arm of the NHS. We've been here now in the system for about 13, 14 years, although we are the artists, previously known as the Academic Health Science Networks, or the AHSNs. So you may have come across as in our former guise, but effectively, we're, I think, incredibly well placed to think about how we support neighbourhood health, because the joy of being in a health innovation network is that you're both local and national at the same time. So although we have our 15 locally embedded, you know, your local friendly neighbourhood health innovation networks across the country, and we are, you know, we do wrap ourselves as tightly as we can around our local systems, we also come together as 15 to make sure that we are spreading that best practice on a national level. We have very porous borders to make sure that good practice that's happening in one part of the country is rapidly taken and implemented elsewhere. So it's a both and way of working, which I think is quite interesting in terms of allowing us, therefore, to unearth somewhere in England where there's fantastic work happening around neighbourhood health, but then rapidly use our networks to be able to spread that best practice everywhere. and local and national is really important to us. I think the other thing I'd say about us is that we obviously have a phenomenal research, development, innovation ecosystem across England. We try and maintain a very kind of disciplined space within that army of support in terms of being dedicated to the spread and adoption challenge. So the NHS, like many sectors, is absolutely amazing at invention. But actually, the challenge that we face, I think, as a system, isn't really an invention challenge right now. It is an adoption challenge. There is fantastic work happening everywhere, and you could throw a dart in a map of England and hit something amazing that's happening somewhere in practice. Our cultural problem is we really struggle to actually lift that best practice and spread and adopt it elsewhere. And there's another lecture series about why that is a problem. It's not this one, but I think just to kind of point that out, because I think when it comes to neighbourhood health and when it comes to the phenomenal energy, activity and intent that colleagues are going to put into making neighbourhood health work, I guess my plea from the outset is that we look out as much as possible and we really try and steal with pride about where things are working and bring those things back into our local patches rather than reinventing the wheel 400 times a week. It's too costly. It means that we struggle with pilotitis, and actually we just don't get the impact that patients deserve as quickly as they possibly could. So I guess that's my soapbox over with. And as I said, it's not an invention challenge. You know, we've already got 3,000 evaluated, evidence-based, in use somewhere, innovative products, pathways, devices. So there's a whole database of what works well, and we've got to do better at spreading that to people. And we're really good at it, I would say. So I love the fact that this is about turning strategy into impact. Our last impact report says, you know, we're helping over 1 million patients with our innovations. But crucially, I think this is really important to neighbourhood health. We're also really interested in jobs and economic growth. So last year, we created or safeguarded 900 jobs. We helped our innovators to leverage over £500 million worth of investment to help to grow their companies. Those companies then create jobs in our local patches. And, you know, as Tom knows, you know, I'm very fond of saying, and it's not an original thought, but, you know, good work equals good health. So when we think about neighbourhood health, it's not just about how we're going to help our neighbourhoods to hopefully alleviate symptoms and diseases that they already have. It's also how do we get really into prevention through good work, good housing, good education, good relationships, etc. I think that's also part of where we need to be putting our attention. So just quickly on the 10-year plan, Tom's already mentioned this obviously, but I just wanted to say, I mean, I really believe that the 3 shifts are a fantastic articulation of the buckets of problems and the buckets of challenges that we have. And I would say this because I'm incredibly biased, but I just don't see how we deliver any of the 3 shifts without health innovation. You know, we're not going to grow an extra 300, 400 members of our workforce overnight. I think we know already about, you know, the financial issues within the public sector. So we've got to do things differently. So I think health innovation doesn't just live within that analog to digital shift, which I think is where people would normally expect it to be. I think when we think about hospital to community and into patients' homes as well, it's going to be technology driven. It's going to be about how do we have safe monitoring? How do we have sensor technology? How do we use data to be able to go and find people where they're at? How do we connect them with the system from their home so that they don't have to travel? Sickness prevention is going to be similar, but, you know, how do we actually give people empowered data to make them help make better choices in life, and also give our employers, our schools and others the kind of data to help people to be more preventative in their daily well-being. So I do see innovation. I mean, I see innovation everywhere, obviously, but within the 3 shifts, I absolutely see innovation at the core of them. And we were really fortunate, you know, to be involved, you know, quite heavily involved in various parts of the 10-year plan. So particularly the innovation research life science chapter, as you'd expect. But I just want to pay reference to the life science sector plan as well, because every time I talk about the 10-year plan, I always want to make NHS leaders in particular just become aware in their peripheral vision about the life science sector plan. There's incredible read across between what we say in the 10-year plan and what we say in the life science sector plan. And when I talk about jobs, particularly jobs in West Yorkshire, across the north, a buoyant life science sector is going to be one of our big bets about how we're going to get inward investment, how we're going to bring jobs into our northern economies. And I really want our NHS leaders to think deeply about their roles, even though you may not feel that they are impactful from an operational NHS leadership perspective. But actually, the decisions we make at the front line really help us to be an attractive destination for global R&D or not. And so I think we all have to think, how do we play our small part in delivering the life science sector plan as well as the 10-year plan? So just a bit about systems then. So obviously we work in systems as health innovation networks. I very, very grandly refer to myself as knit in chief. And it's because it feels like the system needs to be joined up with more of itself. So, you know, we all await the 10-year delivery plan. I don't expect it to be an NHS delivery plan, but a system delivery plan, a community delivery plan, a neighbourhood delivery plan. Because for us working at that system level, you know, the best conversations that we have are when you bring sectors together. So yes, obviously, you know, we didn't deliver neighbourhood health and other initiatives through great engagement with our hospital and our provider collaboratives, you know, increasingly, but also our ICBs. And we're really, really proud in West Yorkshire of our innovation hub model, where we embed fantastic leaders like Amy directly into the ICB to be the innovation arm of the ICB, but also still working with at least one foot clearly in the health innovation network space. But these days, increasingly, and I think this is where the NHS is really starting to look out better, our mayoral combined authorities, our mayoral strategic authorities are incredibly important to this neighbourhood health mission. And so drawing them into this debate about how we set neighbourhood health up to be a success, I think is incredibly important, particularly thinking about the wider social determinants of health, the voluntary community and social sector, universities and research. I was thinking about the fact that, you know, there's the phrase, isn't it, about it takes a village. I honestly think it takes a neighbourhood to deliver neighbourhood health. You know, neighbourhood health isn't going to be something that the NHS is going to deliver by itself. And just to kind of some concluding thoughts on that. This month, actually, we'll see some really interesting work from a gentleman called Charlie Mayfield. So Charlie Mayfield on the role of employers when it comes to employee health. I think we need to fold a lot of what Charlie's going to say into our neighbourhood health plans, because actually we need to be able to go where our people are. You know, neighbourhoods are neighbourhoods, workplaces are workplaces. We need to make sure that we're designing this not around our existing traditional NHS footprints. And I think about that very deeply in terms of the NHS isn't my only customer. Actually, when I think about how employers are going to keep their workforce healthy, I need to be able to make sure that I'm turning to them with the opportunities that our innovation pipeline brings, just as much as I'm turning into the NHS as well. So I think our vision is widening in terms of where do we need to place this innovation so that it's actually delivering real health for our citizens. So we need to go where the need is. We need to go where our neighbourhoods live and work. I think I'm sure this will come from the questions, but it inevitably brings you into this fear of the digital divide. You know, if we really scale health innovation and particularly, you know, tech and apps and digital, are we going to leave people behind? I think it's a question that we can never forget, because it is a genuine challenge to how we're going to be able to do this. I think there are, you know, some very thoughtful people, you know, considering that. But I suppose my one comment I'd make on that is I think it starts with trust. So if we're really going to empower our citizens and our patients to be accepting of the kinds of pathway changes that we're going to deliver to them in terms of delivering neighbourhood health, we can't expect them to be able to receive those things with open arms unless we've already taken the time to really strongly and humbly create a sense of trust between our neighbourhoods, our communities, and our public and even private maybe services. So trust is really important, and we don't go and ask for trust at the point of giving someone an app. You know, we need to have spent the time to deeply embed that trust first. And I think that's a huge role for the ICBs and other leaders in place to really think through. So I think trust is really, really important to that. And very finally, Shaukat, before I hand over to Rachel, people always like to know, so what's in your bag? You know, what's in your bag, Richard? What's in your toolkit of great innovations that might make this thing real? Just a couple to pick out some of my favorites, but Hero of Health, which for me, as dare I say, somebody from South Yorkshire. Sorry, apologies, West Yorkshire. I love West Yorkshire, but it's a homegrown South Yorkshire innovation by a fabulous GP. But it's an AI integrated GP neighbourhood through an app. What that does is it allows patients to access the resources, the local resources that GP surgeries, other primary care sources have, and then promotes healthy lifestyle habits. So it's about the benefits of engagement, not just patients into the NHS, but patients between patients. So creating neighbourhood groups, the organisation of walking groups, health coaching, cooking courses, diabetes courses, but linking patients and citizens with each other, as well as linking them to our services. And Sheffield Hallam University did some really interesting evaluation of that. 94% of patients were empowered to self-care, improving their confidence to maintain a healthy lifestyle. There's a 78% improvement on anxiety and depression, a 30% reduction in falls risk, a 44% reduction in GP presentations, and this is for the finance guys out there, but £600,000 in savings for every £400 for 400 users. That's Hero of Health. And then very briefly, Sweatcoin, similarly an app-based solution promoting active lifestyles. This is about almost the data gamification of how we promote better choices for people. It's about tracking steps throughout the day, offering rewards in the forms of discounts, vouchers for a number of retailers, or even donating to charity donations to charities of your choice. But it's about finding the motivation for people to take healthier behavior and to find the rewards that matter to them in order to make sure that it encourages them day after day to take healthy behavior. So just two examples of innovations. As I said, we have well over 3,000 of these, but I think for me, this is the cornerstone of how we're really going to deliver and empower patients to get neighbourhood health off the ground.
Yeah. Thank you, Richard. I think very, very powerful to get all the details on what's happening with regards to innovation, and especially the examples you shared. So we have heard the national perspective on the overall picture on where we are, and also the system level innovation on what's happening. There are so many exciting things which are happening, but whatever we are doing is for our patients, our communities, right? And it's very important to see what they are thinking, and then how we are coming to their expectations. So before inviting Rachel to talk about patient and community voice, I would remind everyone that after Rachel, we will be asking, we will be open for questions. So please, either you can write your question in the Q&A section, or just raise your hand, and I will give you a floor to ask your question. Rachel?
Fantastic, thank you. I'm going to try my best to come after both of those two talks, but I suppose that in a way I get the easiest part of it, because I get the bit that sorry, that's not actually right, because you are both just as passionate, but I get the bit that I'm really passionate about, and it's about the patient and community voice. So I think the 10-year health plan, we finally got it. We got what we wanted to hear, that patients needed to have power, and that it was going to be guided by patient power. So that was really transformational. But to get there, there's quite a few steps that we have to get to. So I think as a patient association, we absolutely welcomed the patient power. But how do we listen to patients, and how do we work genuinely in partnership with those patients and make sure that they have the knowledge, skills and experience to be that active partner in care, which they tell us they want to be? And to do that, as an organisation, we spent some time a few years ago developing our patient partnership principles, and we worked with patients and healthcare professionals and said, actually, what's it like when we work in partnership? What's it like when our voice is absolutely heard in the system? And the principles started to be around treating patients as equal partners in their own care and in the design of healthcare services. And that shared decision making was that matter, of course, when it came to our individual care. So there's some stuff that I think in the 10-year plan that absolutely gives partnership to patients and gives them that control that we wanted to see. So obviously we welcomed it. But I want to pick up on Richard's point, first of all, because I think if we don't really acknowledge the trust and confidence, we're going to get off to a false start on really doing that genuine, people call it co-production, you can call it anything you want, as long as it means we're working in partnership with patients. And I think the trust thing is absolutely where we have to start, that trust and confidence. And who do people hold trust and confidence in? They hold it in their local communities and in their local neighbourhoods. So we really need to to talk to those local communities to understand that. And one of the things that we really welcome in the plan is around data. So absolutely, 3 shifts are great. We spoke to patients. We put lots of information into the working groups. We did lots of surveys with patients. Our helpline takes 3,500 calls. We asked those as well. We did a national survey to find out actually what are the priorities that people wanted to see, and patients saw a lot in there. But if we think about trust, one of the things we did before the public deliberation on data, which happened about 2 years ago now, is we worked with the department to develop a data pact and to look at what patients wanted in that data pact. So that promise between patients and the system, what was going to happen to our data. And actually, the department were really brave, because I said to them, well, why don't you give me a blank sheet of paper and I'll go and talk to patients? And they were saying, shouldn't we draft a data agreement and then test that in them? And I was like, no, let's start with a blank sheet of paper. And actually, the department were delighted after they had that brave moment of going, okay, we'll start with a blank sheet of paper. And in that blank sheet of paper, it talked about the willingness to share data. But the key thing that I thought was really important in there was them saying, when we do share our data, we know that there's a chance that it'll be hacked. We know that in the world that we're in right now, something might happen to our data. And so we're not telling you to make sure it doesn't happen to our data, but we're telling you to make sure that when it does happen, you tell us. And you tell us what you're doing to keep it safe, and you tell us what you do when something goes wrong. So I felt like that was a real moment where people were saying, okay, we know life's not perfect, but we want to work with you on this. And that was the patient saying, we absolutely want to work with you on this. So one of the things that we really, and I think from a neighbourhood health point of view, will really, really help is the role of the single health record. Something that patients have been asking for forever and a day. So imagine you're a patient and you have complex healthcare conditions, and you have to go in and you have to tell your story time and time again to different healthcare professionals, because that's what's happening to patients at the moment. And I'm sure some of you on the call have experienced that. Some people talk to us about having a suitcase that they pull around on one of those trolleys. They have so much health records. So that's one side of it. But imagine if you had a traumatic experience, then you have to repeat your story time and time again to different people. So the single health record, I think, is going to be one of the fundamental shifts in giving patients power in the system. And the other part of it, from a digital perspective, that we did 2 reports on the NHS app, both of which patients were really impressed and wanted to keep the NHS working for them. But we need to think about how we give patients power, because one of the things patients said to us, and this is about a year ago, they were like, I didn't know you could get the NHS app on a computer. I thought you had to have a smartphone to get the NHS app. So if we explained, so then they were like, oh, you mean I can get the NHS app in the library? And I was like, yeah. And now we have that piece of work happening with the ambassadors and everything else around the NHS app. But they're the things that we can do that genuinely will give partnership to the patients. So then I'm just going to come quickly to the neighbourhood health. And obviously, we're very, very welcoming on neighbourhood health. So we've done work where, we've heard from people trying to get to hospitals where they say, I can get my bus to hospital, but I can't get a bus back for 2 more days because the bus doesn't run. And that probably is quite a lot of the rural areas in Yorkshire that you work in, that just, the cost of getting buses. So to have health systems and diagnosis, one of our reports around being able to get diagnosed locally, where you're not involving those huge travel costs that can happen to people. We had one patient telling us it was £187 return for her to get to her specialist cancer treatment. We really have to try and shift that into local communities. And then building what Richard said, this is holistic. And if we think of inequalities in health, what we hear from patients and what we know, what you all know, and Tom spoke about it too, and so did Richard, is this is more than the NHS. This is about the health and well-being of a nation. And we've got to make sure that systems are designed in areas that work and work for that community. And earlier this morning, I was doing a presentation around emergency care, and we're trying to understand more why some communities end up in emergency care. It's because we do not have the neighbourhood health service in the right area for them, and I think that's going to be fundamental through the development of the neighbourhood health services. And then, of course, we've just got an announcement yesterday or the day before, about the first digital hospital within the NHS as part of the long-term plan. And that's going to keep people in their local communities as well, and keep them well in their local communities. And which has had really good commitment from NHS England and the department that the design of that is going to be in partnership with patients. And that's what patients want, because patients are the ones using the services, and they want to work with frontline staff, because they totally understand the frontline staff are the ones delivering the services, to look at how do we get to a point that we have promised in this 10-year health plan, that everything is designed and delivered with patients and real people, but also making sure that those real people are the real people, that we're not just talking to the same patients all the time, that we're always out there. We're always, like I say to my team in the Patient Association for all our focus groups, are you looking out the window? Are you looking at those communities that we haven't worked with yet? How do we get in there? How do we get that voice of people who are not receiving services properly? Because for me, that's absolutely crucial to the success of the 10-year plan. Now, I've noticed I've probably gone on, so I am going to stop there. But I think the most important thing is that my role as the Patient Association is really ensuring that patients are genuine partners in shaping the delivery plan. I don't want to see a delivery plan that hasn't been shaped in partnership with those people who are going to be using it. And the patients are no longer just the recipients of care, that their voice and agency becomes part of the whole system and leads with staff the development of the system as we move forward. Thank you.
Thank you, Rachel. Very, very insightful, and I fully agree that this is a big topic and is directly related to the health and well-being of all our citizens. So I'll straight jump on a couple of questions, and then we can continue the discussion. So the first question is to Tom. To deliver the 10-year plan and put patient at the center of care requires a cross-sector collaboration. So how do you see the role of cross-sector partnership evolving over the next 10 years?
Yeah, no, thank you. Yeah, no, it's great to hear Richard and Rachel. I think the main thing I would say in answer to that question is that we have spent an awful lot of time in the systems in previous years that I've been involved in, really trying hard to make integration happen between institutions, and making sure that at those levels of meetings that take place, whether it's board level or subgroups or work on population health, and the various winter planning and things that happen in the system, we've tried really hard to make sure that when we talked about integration, that it was happening between the key players. Sometimes I think maybe more focused on things like discharge and a particular part of the system and where it interacts, but broadly speaking about institution to institution. I think the big change that the 10-year plan tries to signal is it signals and it wants to make sure is followed through, which does go with the grain of what I think both Richard and especially Rachel was saying, is that has got to happen for the citizen, for the person. People have got to feel that. They've got to have that trust that Richard mentioned. They've got to have that sense of ownership and engagement that Rachel mentioned. And let's be clear, that isn't easy to hardwire right across really complex systems with people who are really busy doing their jobs, and I've been involved in lots and lots of consultations with citizens over the last couple of decades, and I think, you know, we've got to get. I think we need to get into the slipstream of some of the changes we're trying to make on neighbourhood health and on access to services, and to the way that we're developing any new approaches to make sure that you know, that citizen engagement is happening, and that we've always got in mind, first and foremost, the integration that's happening between the people who are on the interface with the person, and that digital interface as well as the institutional stuff that I think we do a bit better, but we don't focus enough. We haven't focused enough in the past, which is what, you know, whereas my Secretary of State says, and which he's really, really intent on changing, on that interaction and with the citizen and the individual. And just to shout out to support what Rachel was saying about other, you know, not always thinking that people will use the traditional routes or the routes we think they will to access services. That the library, we had something in Leeds called Leeds Libraries 100% digital, it was called, and the aim was to get every single person in the city working, being able to access services, and we basically did it through libraries, and it's a fantastic service, and really, really helps people who otherwise, you know, just wouldn't know where to go and didn't have that sort of technology, either access to technology or that capability to be able to do it. So I do think it's about the wider set of public services as well as just the NHS.
Thank you, Tom, and I really hope that with regards to all the discussions and the expectations in digital data and technology and fulfilling the 10-year plan, we will have right resources and focus for strengthening this area as well, so that we can get the right outcome. So we are really, really looking forward. So the next question is to Richard. Richard. As a distinguished leader locally and nationally in innovation, how do you see the innovation landscape evolving to keep up with the rapidly developing AI landscape? I think some of the things you already mentioned, but if you want to add more.
Yeah, I think so. We've got to the word AI. It's not possible, is it? I think to talk about innovation without getting to AI sooner rather than later. I think the word AI is particularly critical to this conversation. Actually, it comes all the way back to trust again. There's, I think, going to be a distinction made between what we might consider to be technologies that we might be more comfortable with. So I think, you know, the majority of people now would be comfortable with the idea of an app, you know, something on a phone, or as Rachel said, something to be accessed through a computer. But this thinking now about AI and machine learning is another development that we've got to really consider. And actually, one of the more recent announcements has been from our colleagues, our regulator colleagues at the MHRA, who are going to or have formed now a new commission on the regulation of AI in healthcare, which I think is a really, really important intervention here, because we're going to have to, I think, very quickly win the confidence of our population, of our public, when it comes to what AI means within the NHS. And I don't think we have the answers yet. So I think AI is almost a standalone case in terms of potentially a huge opportunity for us, but also something that we can't, I think, sleepwalk into thinking that the public are already accepting of the benefits that it brings. And I think we're going to have to have really public conversations about, you know, both the benefits and the fears about what AI can bring. But I think in terms of, you know, the innovation landscape and how it's evolving, I suppose another one of my question marks in my head, I guess, is we can't leave our staff behind. So we talk a lot about our public and, what technology improvement may bring to them. But actually, we've got, 1.2, 1.3 million staff here. We have to take them on the journey of tech and innovation as well. These are the new tools, new scalpels that they'll be asked to be using. If you're a community nurse out there, we're going to hopefully make your work more rewarding, give you more time for patients, but that's also going to need you to go on a level of training in terms of what that means and how you utilize that. So we need to think very deeply about how we do that for staff, and let's face it, a very, operationally busy, stretched staff base at the moment, and somehow we're going to have to take them on that training journey. So that's another point for us. But in terms of, I suppose, more, because that's maybe two negatives, but in terms of the benefits, I think what we're seeing now, and actually I've cheekily just been looking at the questions, but there's something about the quiet benefits that innovation brings to neighbourhood health. And I was thinking about some of our tools for remote diagnostics, which aren't just taking away pain points for citizens in terms of somebody who would normally have had to, catch two buses, maybe ask a son or daughter to take them to hospital to deliver some basic tests, urine dip tests, etc., etc. And we're asking them to come into hospital to do some very simple things. Using technology now, we're posting kits to patients' homes. They're using really simple apps, using their own smartphones to be able to do tests by themselves. Those tests are then being digitally sent off to labs, and the patient can go about their day. That's massively beneficial for those people who have had a journey eliminated. But actually, it's also showing us that from the equality point of view, there are many people who basically just aren't being captured by our existing screening routes, for whom this is providing an entry point for them, which is far more comfortable, culturally significant, however you want to describe it. And therefore, it's a balancing of the equity challenge in terms of things like screening. So I think that's another interesting point, is it's not just about digitizing or translating things for existing patients. It's about how can some of this transformation actually bring more people to us, because we're actually giving them options that haven't been previously made available.
Very interesting. Thank you, Richard. I think I will straight jump to the next question to Rachel. In the emergence of a digital first generation who don't just want a digitized version of traditional core models, how do we develop an inclusion strategy bridging across the generational gap, the status quo, and the 10-year plan?
We start with people. It's as basic as that. We start with people to understand what they need. And I always argue around kind of the issue that I hear in an awful lot of calls that, older people don't want to do digital. We need to understand where the barriers are and what those barriers are for people to move forward in digital. And I think Richard, in a way, hit the head, because it's the step before AI. And Richard was right but it's all about communication. So we did a piece of work recently, and we've developed a communication model called CORE, and we went into areas of high deprivation and showed some health information, and people were saying, but I don't see myself in this. This isn't talking to me whatsoever. So if we want to understand digital and we want to understand the barriers, then we have to start with people and understand what those barriers might be, because there's a lot of different issues. Cost could be a massive barrier. If you don't have Wi-Fi at home, you can't afford to have Wi-Fi at home. In rural areas, and connectivity can be a big issue. So start with people. I think that's all I really say with this one, is start with people and understand those barriers, and make sure that we build. And digital won't work for everyone to begin with. But what digital does do is it gives access to those people who really want to work it, and then that frees up access for those people who can't do digital or don't want to do digital at this moment in time for a lot of different reasons. But we have to build trust. So it's speaking with patients and building trust about what we're going to do with that data, and speaking in language, in plain English, because we talk about cybersecurity and we talk about all these things. This is not plain English. We've got to start talking about plain English and the benefits of digital for people who may have a fear, and not just be, you've got to do it.
Yeah, well, I think absolutely, and I think as you rightly mentioned that we should start with people, because everything we are doing is for our people and for our communities. So I think if we can just start with our people, then it would be the most relevant for our approach. So I will. There are so many questions, but unfortunately, every time I will just ask one more question to Tom, and then we will conclude. So, Tom. What mechanisms are in place to support a translation of national strategy into local reality, and how is the department balancing central priorities with local autonomy and innovation?
Yeah, I think you'll have heard from our Secretary of State that last year we tried to halve the number of targets that were in the national planning guidance that was put out, and similarly on social care, we tried to do the same, where we were much clearer about and trying to move more towards outcomes rather than inputs and processes. I think that direction of travel will, be still there in the what's going to come out in the autumn, and we'll be really trying to make sure that the guidance, if you like, the instructions that are given from the centre try to enable much more clearly the setting of the priorities that have come from the 10-year plan and from the Secretary of State, particularly around, and actually the plan for change from the Prime Minister around electives, getting waiting lists down, urgent and emergency care, which people care a lot about in terms of their own experience, and obviously GP access as well. So I think an embedding, if you like, and a further attempt to really be clear about the what, and try to be less reduce complexity around the how people are going to have to do it in local systems. Obviously, the neighbourhood health plans, I think, are a big opportunity here at place level to help bind people together and get that wider view of the social determinants of health and inequalities into a plan that the NHS will recognise as one where they'll try and create those conditions for neighbourhood-based service provision and that shift to the community that we've talked about. And I'm very conscious of time, so I'll probably leave it there. But I think that will be the continued desire and attempt from us at the centre to become more of an enabling centre rather than the centralist model that everybody has talked about in the past and that the 10-year plan tries to move away from. Easier said than done, but I think we're moving in the right direction.
Thank you so much. Thank you, Tom, Richard, and Rachel. I think, and then a couple of common themes, whether we talk about the national perspective or system-wide innovation or voice of patient and communities, there are a couple of important areas like how to gain more trust, how to do the engagement, how we can put the people first, and then how all the innovations can translate into the real issues on ground. So thank you so much, and I'm sure all the participants, they have learned a lot from this session. So I on behalf of Health Innovation Network and West Yorkshire ICB, I just want to thank you for your time and all the participants who have joined us today. I'm really happy to also announce that our next distinguished lecture series is on 20th November. With the system transformation at scale, learning from industry. So stay tuned, and then I really look forward to seeing you all there as well. Thank you so much for your time, and have a very nice afternoon. Thank you. Bye-bye.
Thank you.
Thank you.